Good afternoon. I'm Melanie Griffith, Chair of the Budget and Tax Subcommittee on Health and Human Services, here with my colleagues, and we are joined by the Chair and Vice Chair and the members of the House Appropriations Subcommittee on Health and Social Services. Today is February 15th. It's President's Day. Hopefully everyone had a lovely Valentine's weekend. We are going to hear three budgets today. Maryland Department of Health Prevention and Health Promotion Administration, followed by the Maryland Department of Health Regulatory Commissions, and last we will hear from the Department of Human Services Child Support Administration. So for our first budget, members, you can turn to your packets, the budget on Prevention and Health Promotion Administration. We're going to have our analyst, Ann Wagner, take us through that analysis. So good afternoon, Ms. Wagner.
Good afternoon. Thank you very much. Can everyone see the screen? All right, great. So I will be walking through the FICA analysis. Last week we had heard, or I had presented the other offices in the Public Health Administration. And so these are the two largest offices under public health and Department of Health. And so just jumping right into the budget, on this chart, you're seeing that fiscal 20 and 21 are budgeted around 400 million, but fiscal 22 shows a large increase of about 23.5% to showing an increase of $97.6 million. This is driven by new federal funds from the CDC for COVID-19 testing and tracing activities. Although, just like in other offices we've talked about, there is more CDC funding than what is currently reflected in the budget that could be added in fiscal 21 and 22. So I'll move on to our performance analysis section of the analysis. And so this first discussion is on maternal mortality rates in Maryland. This first exhibit compares the statewide and national maternal mortality rates shown as 5-year averages across the past few years. In this 2017 measure, you're seeing that the state's mortality rate is lower and better than the national average, but it has risen almost back to the rate that was seen in 2012. The Maternal Mortality Review attributes this growth to increasing chronic conditions that put women at generally higher risk of adverse outcomes from pregnancy when you are seeing this measure increase, as you're seeing nationally across all these years. And both nationally and in Maryland, the maternal mortality rate is substantially higher than the CDC goal that's shown by this dashed line. So next up, we'll look only at the Maryland statewide maternal mortality rates, but by the women's race. And so here you're seeing that Black women experience significantly higher mortality rates than white women over all 6 5-year averages shown. Notably, the disparity in these measures has almost doubled from back in 2012, when the measure showed that Black women experienced maternal mortality rates that were about 2.4 times higher than white women. Most recently in 2017, this measure is actually showing that Black women are experiencing about 4 times higher maternal mortality rates. So you are seeing that overall the total maternal mortality rates are about, level over the period, but you are seeing among Black women, this mortality rate is increasing, and then among white women, it's actually decreasing pretty significantly over this period. And this trend that you're seeing among the white women showing decreasing mortality rates, this is mainly due to a decrease in deaths that were directly related to pregnancy. So this includes hemorrhages or other medical conditions. And you're not seeing that same declining trend among Black women. So that's why that contributes to this widening disparity. There are multiple committees and task force that have looked at this issue and have issued some recommendations. So just to highlight a few of the recommendations that have come out, the Maternal Mortality Review Committee recommends implicit bias training for hospital staff, and then also recommends requiring hospitals to analyze maternal health outcomes for racial disparities. A stakeholder group has some other recommendations specifically on the racial disparities in maternal mortality. This includes recommending that the state assure that review teams are diverse and that the reviews investigate risk factors by race that contribute to some of these maternal deaths. So social determinants of health or pre-existing conditions are some examples. And then also they recommend that the states begin evaluating data specifically on hemorrhage deaths more, in a more thorough way. And then there was a task force that was established in 2019 legislation on maternal and child health, and they issued their final report this year. Some of these recommendations did also specifically talk about the increasing racial disparities in maternal mortality. And one of these recommendations was that the state decide that maternal and child health should be the third population health domain in the total cost of care model. So that would be along with diabetes prevention and addressing the opioid crisis. So since the report was issued, that has gone into effect. The state has decided that maternal and child health will be the third population health domain. And however, the Health Services Cost Review Commission did authorize fiscal 21 grants to go towards the COVID-19 pandemic, but that's a one-year change, and fiscal 22 grants and onward will be going towards maternal and child health. So then next we'll move on to the infectious disease side of FICA and talk about some of their performance analysis. So FICA has a lot of existing activities that contribute to the state's influenza vaccination campaigns. So this is especially relevant as the COVID-19 vaccine rollout is happening, and you can see that FICA has already had some existing infrastructure for some of the activities they've needed for the COVID vaccines. So coordinating public health messaging, monitoring vaccine supply, and supporting clinics with volunteers when needed are all activities that FICA was already doing for the influenza vaccine campaign for flu shots. This next chart shows Maryland's coverage rate for flu shots over the past 10 flu seasons. You can see that Marylanders overall do show a higher rate of getting the flu shots above the national average, but even at the peak, Maryland only showed about 58% flu shot coverage. This falls below the CDC's goal of 70% flu shot coverage. And so we include this as kind of a baseline to show with FICA's existing infrastructure, which of course, because of the COVID-19 pandemic has been escalated, and a lot of the state's vaccine infrastructure has been expanded to handle the state's COVID vaccine rollout. We wanted to use this as at least a baseline of where the state currently is in terms of flu shot coverage. And most recently in last year's flu season, it was about 58%. So then moving on to the budget discussion, FICA is showing 3 deficiencies this year for adding funds to the current fiscal year. I'll highlight just one of these. So for the Title X program, you are seeing a fund swap of about $3 million in general funds being replaced with federal Title X grant funding for the Maryland Family Planning Program. So there was state legislation in effect that temporarily prohibited the Department of Health from accepting federal Title X funds. This was while HHS enforced any rule that excluded family planning providers or did not require the providers to offer a broad range of medically approved methods and services. HHS issued a final rule that triggered this state legislation because it prohibited grantees from referring patients for abortion services as a method of family planning, among other provisions that triggered this state legislation. And so there was a multi-state lawsuit filed and a case filed specifically for Baltimore City against this federal rule. And on September 3rd of this year, a federal court decided to block the HHS rule for the Baltimore City case. So this meant that the HHS final rule couldn't be enforced statewide in Maryland, and then this allowed the state to begin receiving Title X grants again. So that's what is kind of backing up this deficiency, is that FICA is again receiving Title X grants, at least in federal fiscal 21. And so you're seeing the $3 million in general funds that were supporting family planning in Maryland being replaced with those federal funds again. And then in terms of other fiscal 21 actions, I'll just briefly talk about the cost containment actions that the BPW approved on July 1st. There were a few reductions in FICA, including one-time cuts to the grants for the Capital Region Medical Center and the statewide academic health centers of $1.5 million reductions for each grant. Moving on to fiscal 22. So the allowance, this chart shows the fund sources in FICA's budget. And here I just want to highlight the fact that the state's public health infrastructure and activities in FICA are largely funded by federal grants. The federal grants make up about 61% of this budget, whereas state funds make up the remainder, with general funds only making up about 11%. So that kind of shows that when you do see larger funding changes in FIPA, it is often related to the federal grants it receives. In terms of the budget change, again, you're seeing a $97.6 million increase in this budget. This is mostly driven by those CDC funds for COVID-19 testing and tracing. So you can see here that 24 million goes to a major IT project and 60.5 million goes towards planned testing and tracing in fiscal 22. So then moving on to Exhibit 8, that $85 million is part of a larger CDC supplemental grant that will total $206 million coming to the Department of Health. So while only $85 million is reflected in the budget, the department did provide some more information on how it plans to spend the total $206 million grant. The most of this funding, or the largest item, is for contact tracing. And this amount does include the National Opinion Research Center contract for the state call center. And then it also covers the development costs for a major IT project. And so Appendix 2 does provide a little more information on that contact tracing platform that those funds are supporting. Overall, it's going to cost about $28 million, with the majority of that funding in 22. And I will just note here that this COVID contact tracing platform is separate from the phone app, the COVID alert emergency or exposure notification system. Though that program was developed by Apple and Google at no cost to public health agencies. And so this specific IT project has to do with the platform and network that allows local health departments, the state call center, and the State Department to coordinate how they contact people who tested positive for COVID-19, and then also their contacts. So that's what this platform is supporting. But then going back to the more general $206 million grant, this is what was awarded in this past interim, but in the December stimulus, the department actually received another grant for similar purposes for testing and tracing, and that will total $348 million, none of which is shown in the budget so far, and the department is still working on developing a budget plan for those funds. But that is funding for testing and tracing that's on top of the $206 million grant. Then I'll skip ahead. So I'll talk about the one issue right up in this section. So talking about the Supplemental Nutrition Program for Women, Infants, and Children, referred to as WIC. The department did receive a few program flexibilities and federal waivers to change how this program runs, mainly to limit in-person interactions for women and participants of this program needing to come into the clinics to be certified or to receive their benefits. So some of these federal waivers are shown here. And we just wanted to highlight how this program has changed. We also wanted to look at how enrollment in this program has changed over time. Since 2016, and every year, WIC enrollment has decreased in every single participant category. And unlike other public benefits programs that saw increases in as a result of the pandemic, you're seeing that WIC enrollment did continue to decline in fiscal 20, although it did, the rate of decline slowed a little bit to only decreasing by 1.5%. Because the WIC program is entirely federally funded and the federal grant is based on enrollment, this declining enrollment does lead to the state receiving fewer federal funds for the WIC program. So in 22, there's about a decrease of $8.7 million in federal WIC funding as a result of this declining enrollment. There was 2019 legislation that asked the Maryland WIC program to look into the declining enrollment and to offer some analysis of why the enrollment is going down, and then also provide some recommendations for expanding enrollment and keeping participant retention. So MDH submitted this report and discussed findings from a user survey it conducted. And the department found that 34% of survey respondents did have issues redeeming their benefits. And that was most commonly due to either not being able to find the certain foods they were looking for, or they couldn't redeem their benefits because store employees had refused to run the WIC transactions. So this was some of their findings from that survey. And then FIPA had discussed the the list here of policy changes that would ideally improve enrollment and retention in the WIC program. And so we asked the department to first explain some of the initial impacts of the pandemic on WIC enrollment into fiscal 21, and then whether it is requesting that the federal government extend any waivers beyond the state emergency or state of emergency. And then the department should also provide a status update on implementing any of the mentioned policy changes here. The DLS recommendation is to overall concur with the governor's allowance, and that concludes my presentation. I'd be happy to answer any questions.
Thank you very much, Ms. Wagner. That was a lot. I know it's a lot of information. We have a question from Vice Chair Valentino Smith, and then Senator Young, you're on deck.
Thank you, Ms. Wagner, and I'm going to save most of my questions for the secretary. The only thing I'm going to ask you to do is your presentation was very, very good and detailed. Last year, it was either last year's analysis or the year before, you were able to get from the department and WIC a breakdown of where the decline was, because it's sometimes women getting formula, but we were seeing the biggest decline in the children getting food. And so I'm wondering in your bar graphs, if you can go back and work with the department to get us the data then on the, let's see, women served, infant served, children served total. Okay. So it seemed a little bit different than last year. So you do have it. Sorry. That's a delegate not paying as much attention. Sorry. So children served, we're still seeing the decrease.
Yeah, there was a decrease in every category. Yeah. I think the largest increase was in the women served.
Women. Right. But they're the children too. All right. Thank you. Sorry, Madam Chair.
Sorry, delegate. Was that your final question? I think you got muted.
Oh yeah, no, sorry. I didn't appreciate the significance of the detail on that chart, and now I do. Thank you, Ms. Wagner.
No problem. Senator Young.
Thank you. I had 3 questions, but actually I guess 2 of them might be better for the secretary. But back to the mortality rates. Are they just from hospitals, or is that mortality rates overall? I'm trying to look at why the mortality rates for Black women so much higher.
Right. So this does look specifically at deaths that are directly related to the pregnancy. So that would, I mean, there are different definitions for the maternal mortality rate, and I believe the department could kind of show the differences a little better with how the CDC defines it versus the reviews that they do. The department tends to review more cases like within a year of pregnancy versus the CDC, I think, keeps it to within 40 days or around that mark. So, but yeah, I would say that this rate does focus specifically on the deaths that are directly related to the pregnancy and the health outcomes, I would say.
Are there studies showing why that exists? Are Black women getting as much care before?
There's the annual maternal mortality review that this data came from, and the review does go through in more detail about prenatal care and some of the risk factors, although there was that recommendation that the annual reviews do look into more risk factors like social determinants of health and pre-existing conditions. But I can send you the most recent mortality review that does dive deeper into this issue and, you know, looks into some of the context and in some of these cases.
Yeah, I just think if we had that, we should certainly be able to narrow that quite a bit, if not correct it totally. But, all right, thank you.
Thank you. Any additional questions for the analyst? Okay, seeing none, we will turn to our panel with the Honorable Dennis Schrader, Acting Secretary of the Department of Health. And Mr. Secretary, if you want to introduce those that you have with you, we have a lot of folks signed up, but you can let us know who you have with you and how you'd like to proceed.
Thank you, Madam Chair, and members of the 2 committees. I want to first thank the analysts for an excellent report. We have submitted all of our responses in writing. And today I'm joined by our Deputy Secretary, Dr. Jinling Chan, and our Chief Financial Officer, Jordan Butler. So I'm going to turn this over to Dr. Chan, and she'll introduce her team, and we'll answer questions.
Thank you, and good afternoon, Madam Chair and members of the committee. Appreciate your time in reviewing our budget. Appreciate the budget analysts and the detailed work that they did as well in analyzing the Prevention Health Promotion Administration budget. I am joined here today by Donna Google, who is the director for PHPA, as well as Courtney McFadden, her deputy director, David Davis, the Director of Budget and Management for PHPA, as well as Jennifer Wilson, who is the Director of Maryland WIC, and we are all available to answer your questions. So thank you.
Thank you. I'll see if there are questions from the members first. Okay, Vice Chair Valentino Smith.
All right. Thank you, Madam Chair. So I just sure they're not presenting anything. We're just asking questions now.
Yeah, that I do. You're making an excellent point, Madam Vice Chair. We do, Dr. Chen, have several specific questions that the analyst raised. I didn't know if you wanted to speak to those first. I know that you have presented us with some testimony in writing, but we do have some folks that are watching that may not have access to that. So I know there were some specific questions related to, I don't know, I'll let you go, Delegate. I was going to bring it up.
Okay. All right, so I just was, I mean, I've been reading the testimony and all, but so I do then have at least 4 or 5 questions, and you can cut me off if I've gone too far. On the infant mortality, I'll wait because I think Senator Young asked some questions that you'll follow up with, so I won't delve into those. But I want to know if you're tracking in infant mortality those that are covered or not covered by Medicaid, and whether we're seeing some downfall in what is happening either in our fee-for-service or in our Medicaid managed care organizations in terms of what they're doing and working with this population. So are these covered generally, this population? I'm assuming Medicaid should be a big player in this.
So thank you for that question. And so in terms of infant mortality, we of course are always taking a look at that because it is one of our key indicators. And we do work with our Medicaid partners regarding infant mortality and all of the other, wraparound services to prevent infant mortality. I don't have the data in front of me in terms of what proportion of deaths among infants are associated with Medicaid covered pregnancies, and would ask if my Deputy Director for FIPA may have additional information. Courtney? And if not, we will get back to you with additional detail about that.
Thank you. I'm just going to suggest, before I move on to my next question, if we're talking about in here, adding it into the total cost of care as one of the, third parameters now that they're looking at, I'm going to ask in the response on whether or not the MCOs have been given any additional parameters to meet and outcomes to meet with respect to the contracts that they have with the state or this population. The next question I had to do with respect to code spending. And so I think the analysis is on page 14 and 15. So here we're being told that $85.1 million has been spent. And we see a plan on page 14 for the rest of the $205 million. And then we're being told that there's another $348 million to come. And so my question is twofold for the department. One, first, is there a deadline upon which this money has to be spent, each of the two parts of the money, the 200 and then the 348, the deadline? Were there designated parameters or did you have discretion for the spending? And then I'd like you to follow up with the analyst to give us a county breakdown, especially with respect to the funding distributed to the local health departments, so that we can see how this is being spent, of course, with an interest on a lot of resources at least being expected to be put towards the jurisdictions that have some of the highest infection rates?
Madam Chair and members, I would start by saying that this is 2-year money, and this is a 2-year grant. Of course, we've been spending against this, particularly in the early going with contact tracing and laboratory services. But I'm going to, for the detail, ask our CFO to address the detail of where the money stands.
Hi there. Thank you, Dennis. Thank you, Delegate. You've asked a number of questions, so let me see if I can answer them all, and then let me know if you have any follow-up questions. You are correct that we have a $206 million ELC grant that was awarded to the department, I think, last summer, in early summer. There are parameters around that grant from the CDC. It is funding specific for testing, surveillance, and contact tracing. And so the FY22 budget anticipates $85 million, and that $85 million is budgeted in the governor's allowance. We are spending some of that $206 million in this fiscal year, and we will be appropriating more authority so that we can reflect that spending on our current year's books. And then in addition, after the governor's allowance introduced to the General Assembly, we did receive another award from the CDC. This award is a supplement to the $206 million grant, and it's also for testing, surveillance, and contact tracing. We're still working on the spend plan for the $348 million supplemental. I believe that's due to the CDC in mid-March, so we're actively working on it. To your question about the local health department allocation of these grants, we did allocate a certain amount of money from the $206 million grant to the local health departments. I believe it's around $27 million, and we can provide that breakdown for you. And then we anticipate that there's going to be another local health department allocation from the $348 million award that we just received. And once we determine that allocation, we can certainly provide you with the jurisdictional breakdown.
So it's almost like, let's just go, you're going to spend all the 205 million then, or show us how the 205 million is spent, show us the General Assembly and a budget amendment for this fiscal year. And then the 348 you expect to be in the next fiscal year?
So on page 14 of the DLS analysis, that's the complete breakdown of how we intend to spend the $206 million grant that we already received.
So that would be this fiscal year?
It's going to be in this fiscal year, FY22, and a little bit of FY23. This is a 30-month grant that ends in fall of 2022.
I'm sorry, Madam Chair. I appreciate your patience. I'm feeling a little frustration at the sense of urgency of wanting the money to get spent. So we'll get an update in March then on your plans for the 348. It sounds.
Yes, and I will say, even though that the $206 million grant, for which we have the breakdown in the analysis for your benefit, we are being urged by the CDC to spend that money as quickly as possible. So even though we do have a long time horizon, we're trying to front load the spending rather than stretch it out over that 30-month period.
Well, thank you. I look forward, you'll send to our analysts then the county breakdown by health department, and in March, your plans for the 58. Just a final question then. In Appendix 2 on page 23, we talk about a lot of money that was spent on the technology for contact tracing. Generally, I just find contact tracing to be completely ineffective if we're not getting testing results quick. I mean, if you're not getting your test result back for 3, 4, 5, 6, 7 days, all this money in contact tracing seems to be really not well applied. But does this same technology, is it going to work to help with vaccines and vaccine administration? Or are we talking about a completely different platform now Or is there an avenue to use this, very specific amount of money and all this big platform and technology? Is it going to cross over to vaccine administration assistance?
Let me take that one. So this is intended to provide both the capability to surge, because we needed a very large surge in contact tracing, and our expectation is that this money, because contact tracing is a routine function of the department, but at a much lower threshold on a regular basis. So this money was spent with the idea of integrating it into our normal department operations post-COVID. I don't know if that answers your question.
So are you anticipating a spend then in technology for vaccine administration? Because obviously we're painfully seeing some stumbles in the ability of the state and county to have a platform that's a single point of entry or coordination for vaccines.
Yeah, that's a different topic, but we have a whole separate stream of money that we're putting in place for technology for vaccines, and what we have realized is the system that we had in place goes back to 2001, and we have been putting a lot of money into high-speed appointment systems that are being rolled out as we speak. So we can talk about that at another time. We'll pull that information together for you.
Okay, well, thank you for your patience, Madam Chair. Thank you for allowing me the opportunity to try and clarify some of this complicated spending.
Absolutely. Thank you, Madam Vice Chair. We'll turn to Senator Young.
Thank you, Madam Chair. I have two questions, but I guess the first one's got two questions within it, and it certainly relates to what the delegate was just talking about. One, do we have any discretion in using that contact tracing money otherwise? And I'll finish this point. I almost feel like right now with the contact tracing that the bus went by and we're chasing it. We should have had the contact tracing when it was at a much smaller scale, and we could have followed up and prevented it. Now it seems to me it's far more important to get needles in arms. And if we get enough needles in arms, the contact tracing becomes less important. So do we have any discretion, and why wouldn't we look at trying to get more vaccinations faster?
Yeah, on the discretion part of it, I'm going to ask our Chief Financial Officer to address that, and then Dr. Chan can handle the second part of the question. Go ahead, Jordan.
Senator, the funding that we were just discussing does have limitations. Those three limitations are testing, surveillance, and contact tracing. So as long as the money is used for one of those three activities, the spending is eligible. We unfortunately cannot use this money for vaccination activities.
Okay.
If I could add one other point before Dr. Chan, when it's only become evident in the last 90 days that we were actually going to have a vaccine available. So our total focus has been, and it even continues to be now, is to pay, we've got testing, contact tracing, PPE, and surge. The good news is the surge on the third wave seems to be receding, but we still have to be spending and focusing on testing, tracing, and PPE for the foreseeable future, because it's going to take a long while to get 6 million people vaccinated. So the spending in those categories has been our primary focus, because that was our only defense until recently with the vaccine, and we need to continue to focus on it over the next many months until we've got a very high percentage of the population vaccinated. Dr. Chan, did you want to add anything to that?
Thank you, Secretary. And I would say that the level of contact tracing that the department and our local health departments have been involved with over the last close to a year is unprecedented compared to any other infectious disease that we've done contact tracing for. So even early in the pandemic, local health departments and the Department of Health were engaged in contact tracing, and we quickly ramped up a significantly higher and greater resource capacity using COVID Link as the common platform where local health departments and our contractor with NORC were engaging with contact tracing. We continue to expand on and enhance those efforts. And so those are still critical elements of our response, as the Secretary indicated. Thank you.
Okay, thanks. It sounds like we've got limited capability of switching, but again, as Delegate Valentina Smith said, we're getting tested and getting results an hour later, at least on the short test. But I know at some of the locations, people are still waiting 3-4 days a week sometimes. And if that's the best test we have, I think the contact tracing is proving ineffective because the people are all over the place before they even know they're positive. So that has to be dealt with in some way. We need instant results. The other question then, I assume we're keeping records on where the being given and how many. I heard earlier that with flu, it's kind of more like a survey. Can't we develop an instrument where both with flu and COVID, we actually know how many people are getting it, so that we can design PR campaigns around getting more people to do it? I didn't know that the flu, for example, was that low a percentage. And if that's the best we ever do with COVID, we're going to have a long-term problem. So I think, one, we need to have that data, and two, then know what to do to respond to increase those numbers. So if you could comment on that.
Thank you, Senator Young. I think your question broke up right at the beginning, but if I understand it correctly, you were asking whether or not we track information on people who are receiving COVID vaccine in addition to flu vaccine. Is
Yes.
that correct, sir? So we do track that information. That is captured in the state's immunization information system called Immunet. And that is where we're pulling information from on a daily basis and is the primary source of data that is on our COVID vaccination dashboard.
I thought I heard earlier that flu was done by a survey, not an actual tracking. Did I mishear?
Yes, and so that is slightly different. And, recently we are requiring that all vaccinations be entered into Immunet. And so historical data is not as available. However, with COVID vaccine, it is required that every provider who is using COVID vaccination and is vaccinating people, that they enter that data into our Immunet system. So we are capturing all of the COVID vaccines that are delivered by providers here in Maryland.
And we'll be doing the flu in the future.
I believe so, yes, sir.
Okay, do we design programs around reaching those people that aren't doing it to safety? And
so with flu, we are looking at how we might be able to use that data going forward. With COVID vaccine, absolutely, we are mining that information and looking at where the people are who are getting vaccinated to help us, again, working with the Equity Task Force and others to really target future vaccination efforts.
okay, thank you.
Thank you, Senator. Senator Rosepep, were you done, Senator Young? Okay.
Yeah, yes.
Great. Okay, Senator Rosepep.
Thank you, Madam Chair. On the tracing issue, I get it that the federal money is restricted in various ways. My question is, based on the money that you've gotten so far with CARES 1, 2, 3, and 4, how much how many months out do you have the money to do tracing at the state scale that you believe it needs to be done? Is it 1 month? Is it 20 months? Because you know that obviously the Biden administration, the Congress are going to come through with another package. So I'm trying to understand how much money how much fuel you have in the tank to do tracing right now, for how long, and how much more fuel you need to keep doing tracing to the level we need to do it over the next year or two.
So thank you, Senator Rosepep. And I would say that we have the ELC dollars, as our CFO, Jordan Butler, outlined. What it is intended to cover is testing, contact tracing, and surveillance. And with the supplemental budget, it is all, will be funded for at least 30 months.
So you have enough money to do all the tracing you think you need to do for 30 months from now?
That is certainly our intent, sir.
And at what scale of testing and tracing is that? That's how many, an average of how many tests a day for how many days?
So right now, we have done in the state close to 7.5 million tests. And beginning in June of last year, we've been doing contact tracing on not only the individuals who are testing positive on a daily basis, but also, from PCR, as well as with antigen tests that started in the fall. So we've been doing that contact tracing.
Right, but I'm talking about forward.
I'll have to get back to you with those specific numbers. If you would like specific numbers on our planning, is that what?
That's what we need. Just, if I may, Madam Chair, Delegate Pena-Melnick and I have a bill on exactly this issue. Is getting a plan from the department for their future plan on testing and tracing, and the money needed to do it at the scale we need to do it, because the department, the Secretary is absolutely right. Vaccines are wonderful, but they're not going to solve all the problems immediately. So testing and tracing is critical for quite a while. And so I'd love to have whatever information you have on that, because we want to help you make sure that we're doing all the testing and tracing we need as long as we need to do it. And if we don't have enough money, we need to get the money. Thank you very much, Madam Chair.
Thank you.
Mr. Vice Chair. All right, I'm going to just ask a couple of questions, members. I do recognize we have a couple of witnesses signed up on this budget, and I have a couple of other budgets to cover as well. But I wanted to acknowledge certainly the deep concern that I've heard from the committee, and I know you all share when we look at the numbers related to infant mortality and maternal mortality here in the state, particularly for our women of color. I know that there has been some deep dive work by commissions, and we have legislation coming up this session that will deal with prenatal and postpartum care, also trying to direct some funding towards health disparities. But I wanted to give you an opportunity, if a member of the team wants to speak to that, that very, very critical issue in our state, because we are seeing the numbers move in an alarming direction. And then my second question, Delegate Valentino Smith and I have been talking offline, and I know you all provided some information in your written remarks about the Women, Infants, and Children's program, but we are concerned about the numbers of eligible but not participating women across the state, but particularly in Prince George's County. I know you all did a report in February of 2020. We'd like to hear if there are any updates. And Senator Rosepep, if you can mute your phone. I was going to see if I could do it. Okay. So if you could speak to the Women, Infants, and Children's program and any update that you might have as it pertains to that.
Great. Thank you, Madam Chair, for your questions. So let me take the first one. There have been some changes, I believe, to the federal eligibility requirements for the WIC program, and that has impacted some of Maryland's numbers. And I would ask if Jennifer Wilson, the Director for Maryland Medicaid, may be able to speak to your question in more detail. Jennifer, Ms. Wilson.
Good afternoon. Thank you, Dr. Chan. Related to the question regarding eligibility and percentage of folks who are actually enrolled, when you look at Certainly, we would love to be greater than the 70% where we currently sit as far as enrolling and potentially eligible. Of course, those numbers are based on Medicaid numbers. Unfortunately, that is something that is, a national problem. Unfortunately, Maryland is number 2 in the nation as far as the greatest percentage, which is fine, but it doesn't do anything for the number of people. So trying to really look at trying to update any kind of our outreach that we have available, is certainly something that we had done even pre-COVID. And it's certainly kind of changed, direction a little bit, focus area a little bit different during COVID. But certainly something that we have our eye on.
Great. Thank you so much, Jennifer. And then, Madam Chair, in response to your first question about both infant mortality and maternal mortality, and specifically the racial disparities that we've seen and that the analysts highlighted in the analysis, we are very acutely aware of that, and it is one of the reasons why, with the support of Secretary Schrader, as well as the HSCRC and partners around the state, that one of the key indicators or metrics that we are really focusing on through our state integrated health improvement strategy, or the SIHIS, that has been included as one of them, one of the key metrics that we're focusing on. Under the leadership of both Courtney McFadden, who's on the line, as well as Dr. Shelley Chu, who is our director for the Bureau of Maternal and Child Health, we're looking specifically at what some of the underlying conditions may be that are contributing to these disparities among women of color, and trying to integrate and improve and expand some of the initiatives that we have had in place over a few years that we want to focus more on some of the quality initiatives regarding maternal high blood pressure, for example, as one of those initiatives. So I didn't know, Courtney, if you would like to have any or make any additional comments.
Thank you, Dr. Chang. I'd just like to highlight a few initiatives that we are undertaking specifically to address disparities in maternal mortality. And so as Dr. Chang mentioned, I mean, the biggest one is SIHIS, signing on to decrease severe maternal morbidity. Is on the continuum of maternal health, with maternal mortality obviously being the most severe outcome. But we are focusing on reducing morbidity. We are also a part of the MD Mom program, which is a HRSA funded grant in which we are collaborating with Johns Hopkins and UMBC. We are tasked with convening a maternal health task force. We are also a part of their activities included to provide implicit bias training to perinatal providers in the state, which is also a requirement of House Bill 837 that passed last year. And so as of right now, we have 30 of the 32 birthing hospitals that are signed up for the initiative with the implicit bias training. Another initiative is we have relaunched our perinatal neonatal quality collaborative, which is a collective group of birthing hospitals that have volunteered to work on a measure that they have made consensus on to decrease disparities in outcomes. And so what they've chosen right now to focus on is maternal hypertension, which is a contributing factor to Black non-Hispanic women with regard to maternal mortality. And so we're excited to relaunch that collaborative. Right now we have 25 of the 32 birthing hospitals that have joined the goal. And we're excited about that, particularly with COVID going on. We were really happy to get those 25 signed on. And then lastly, I'll mention the department, through the Maternal Child Health Bureau, has invested about $12.8 million in fiscal year 21 to efforts that will decrease maternal mortality and maternal morbidity. And that includes everything from our family planning programs to our care coordination, connecting women to resources in the community, doing maternal mortality reviews, and fetal and infant mortality reviews. Thank you.
Very good. Thank you very much. I think what you've heard from the members is a deep concern, and based on your response, I know that you share it. So I hope you know that we're here as partners as well. And that's why the questions about WIC becomes so relevant to us, because we understand that, diet is one of the contributing factors to some of those root causes or social determinants of health that you've defined, that you're trying to address through your multifaceted program. So I hope that you'll keep in touch with us, keep us updated as you start to see outcomes from the investments that you're making in care coordination and other interventions, because these numbers, we've got to watch them very closely. We had made some progress some years ago, and so we want to get back on track and make sure that we're doing everything we can to address these critical impacting influences of the healthcare and outcomes of our women and children.
Thank
All right.
you so much, Madam Chair. Yes.
Thank you. Any other comments, Mr. Secretary, your team members, any questions?
No, Senator, thank you very much. We appreciate the time today, and we will take all of these comments and questions to heart and move forward. Thank you very much.
We appreciate that. Thank you, sir. And thank you to you and your team and the analysts. We do have some members of the public who've signed up for testimony. I have Kevin Cullen, I think William Nelson, John Groupman. We'll start there.
Thank you, Madam Chairman. I'll be very brief. I'm Kevin Cullen. I'm the director of the University of Maryland Marlene and Stuart Greenebaum Comprehensive Cancer Center, and I'm here to thank the strong supporters that we have had in the House and Senate over the years for the cigarette restitution funds, which have been directed to cancer research at the University of Maryland and at Johns Hopkins. We are an NCI designated cancer center, one of some 70 in the country. We are one of about 50 comprehensive cancer centers, the highest designation, and we're about to renew our designation this year. With the cigarette restitution fund dollars, we have been able to continue our strong outreach efforts throughout Maryland. Since its inception, we've screened 37,000 people for cancer and have made more than 150 cancer diagnoses with a 95% survival rate. In terms of research, just since our last NCI renewal, we've put more than 3,000 patients on interventional trials. And unique among cancer centers, 45% of our clinical trial participants are underrepresented minorities around Maryland, which with a national average of around 3%. Two noteworthy trials that we participated in recently, we've a drug that was invented at the University of Maryland with the support of the Cigarette Restitution Fund is now being tested in pancreatic cancer, where there's a critical unmet need. We've also been able to pivot to respond to the COVID crisis. A compound invented by Maryland investigators was used in patients with advanced COVID and has been shown recently to have reduced mortality in that group by as much as 50%. And Merck is now trying to push that forward rapidly to the FDA to get it through a fast track approval. Another important mission of our cancer center is education, training the next generation of researchers and scientists. We're the only center in the country with 5 federally funded training grants that range from middle school to undergraduates. And in the last 5 years, more than 300 underrepresented minority trainees have participated in those programs, including middle schoolers here in West Baltimore. So with the Cigarette Restitution Fund support, we've been able to grow and mature tremendously as a cancer center. In the past 5 years, our federal funding for cancer research has increased by 77% because of the critical mass that we've been able to develop and the excellent faculty that we've been able to recruit with Cigarette Restitution Fund dollars. So I thank the members of the committee for the support through the Cigarette Restitution Fund, and I feel very comfortable saying that this investment for Marylanders has been a very, very good one and deeply appreciated. Thank you, Madam Chairman.
Thank you. Mr. Groupman?
Mr. Groupman is on mute.
You can unmute yourself, sir.
I'm uncharacteristically muted. So if it's okay, I'd like to defer to Bill Nelson first, and we're going to do a little bit of a tag team if the committee will indulge us.
Fair enough.
Well, thank you, Madam Chairperson Griffith. I join my colleague Kevin Cullen in thanking you and all of the Maryland legislature for your steadfast support over the years for the use of a portion of the Maryland Tobacco Settlement Funds to support research at our state's two great cancer centers. Of course, this has been an incredible year for healthcare generally, of course, but particularly for people confronting cancer. Since the first 3 cases in Montgomery County in March, both cancer centers have had to almost completely reinvent the way they care for people with cancer, people with COVID-19, and people who have both. Of course, you can't mitigate cancer just by quarantining. The good news is that there have been some incredible unforeseen benefits of the Cigarette Restitution Fund investments for COVID-19. The molecular diagnostics laboratory here that does the cancer genome sequencing was the one that launched right out of the gate a COVID-19 test. A GMP manufacturing facility that we had supported by the Cigarette Restitution Fund over the years turned around and redeployed itself to make more than 100,000 test kits for use here in Maryland. And of course, Kevin Cullen and I got together, experts from both centers, to give the best possible advice to the Department of Health on what the specific issues were related to vaccinating people with cancer, when they should be vaccinated, and how. Interesting enough, last spring, the Dean and CEO at Hopkins, Paul Rothman, asked me to chair the overall COVID-19 Clinical Research Committee for all of Johns Hopkins. Our Deputy Cancer Center Director, Elizabeth Jaffe, was charged with managing the Prioritization Committee. And our members, and this is true at both cancer centers, were coming up with new treatment strategies for COVID-19. Kathy Handy Marshall, who many of you met last year, a young African-American prostate cancer clinical researcher, discovered, of course, that there's a target that's shared, imagine this, between prostate cancer and COVID-19. So she's launched a clinical trial targeting COVID-19 care in addition to her work in prostate cancer. The other young African-American basic science researcher that you all met last year at our testimony when we could be in person, Jelani Zarif, has had an incredible year, launching 4 high-impact scientific papers, ushering in a new wave of how immunotherapy is going to work in the coming future. And finally, everyone's still been working hard on cancer research, and we continue to launch new companies at both cancer centers. One of them, called Delphi, started in the Canton neighborhood of Baltimore, just announced last month that it raised $100 million of Series A funding. That's new jobs, new economic activity for the state, which we're going to need moving forward. Thank you very much for all your help, and let me turn over to John.
Thank you.
Thank you, Madam Chair. So I've been involved in the CRF program from its inception, starting with the National Tobacco Settlement in the late 1990s and real landmark legislation that where the state of Maryland was the pioneer and the leader. And indeed, when Kevin Cullen, Bill Nelson, and I get together, we talk about the incredible wisdom and long-term investment that you and the legislature and the state as a whole has made in this endeavor. And when I first moved back to Maryland in 1990, cancer statistics in the state were, to be blunt, dreadful. The success since that time, overall cancer mortality in the state of Maryland has dropped by 50% over the last 30 years. That exceeds some of the success of the United States as a whole, and Maryland is a leader in this regard. Much of it is due to the reduction in tobacco use and the tobacco control efforts, but a lot of it is due to the investment in the basic and clinical research that has been promulgated by these funds. Just to give you a quick update on several of our young faculty and the work that we're supporting with the CRF initiative. Panagis Galiastos has done, is an assistant professor, has done some really pioneering work in addressing a number of the various tobacco use products. As all of you are well aware, e-cigarettes and a number of the new tobacco products are potentially a gateway to tobacco use and something that we need to be constantly surveilling on. The other is Dina Lancy, who's a newly appointed assistant professor in our cancer center. Her work is on reducing the barriers to minority recruitment to clinical trials. and working in partnership with the Department of Health in Maryland and with Otis Brawley, who's our Associate Director for Outreach and Engagement, there have been a series of outreach efforts to attempt to address the colorectal screening issues with respect to African Americans in our state. And so collectively using these resources that we have, which now amounts to well over 20 years of support from the state, has been the type of long-term, consistent types of support that has allowed us to make some of the major achievements that have been achieved by our institutions in the state. So thank you very much. Happy to answer any questions.
Thank you very much. Thank you, all three of you. Are there any questions for these presenters? Okay, thank you very much. We'll move to our next witnesses on the list. I have a Michael Brozick, and I have Nathaniel Richardson from University of Maryland Capital Region Health. Good afternoon.
Good afternoon. And thank you, Madam Chair Griffith, Mr. Chairman Resnick, and Madam Chair, Vice Chair Valentino Smith. For the record, I'm Nathaniel Richardson. I'm the President and CEO of the University of Maryland Capital Region Health. As Senator Griffith, Senator Rosepep, and Delegate Valentino Smith are aware, I've held this position for about 10 months here in Maryland, and I have been honored to serve in the Maryland community. While not quite a year, I will tell you there's been a plethora of work that has been done here in Prince George's County planning for our residents in Prince George's. A lot of this work over the last 8 months has focused around access and making sure that our Prince Georgians not only have access, but they have access in the right places across our county. I am an official resident of Prince George's County, and I have lived with this burden throughout this pandemic that we have seen specifically in Prince George's County, and specifically related to our COVID pandemic. As we know, Prince George's has been the epicenter with so much burden from the COVID efforts and disease. We continue to work as a community partner in the vaccination efforts. I have the bilateral responsibility of making sure the long-awaited opening of the new University of Maryland Capital Region Medical Center is successful in June, and my goal is to make sure that it exceeds the expectations of every member on this WebEx that have on this Zoom that has participated in investing in that structure in Largo, as well as making sure that our Prince Georgians are proud of the work that we will do there in Largo. To that end, I appreciate the opportunity to share the work that has been done to date before the subcommittees to build a best-in-class healthcare facility in Largo, as well as a healthcare delivery system across Prince George's County for our residents, the Southern Maryland region, and our state. I will say first, as we all know, change is necessary to sustain such healthcare infrastructure across the county, but that change requires investment, which all of you I'm asking to support and continue to support this bill and this effort. I will tell you over the last 8 months, we have finally solidified and completed our leadership infrastructure. I'm the 5th CEO in 8 years, and we've had a multiple turnover of our executive leadership here at the University of Maryland Capital Region Health. And with any change of that substantial rate, it's hard to make your organization move forward and to have movement and move the needle. So we have finally got a leadership team that's in place that I feel will truly make a difference in how we serve across our Prince George's County. We have implemented a service excellence program to help us with our culture and our structure related to service excellence and serving our residents. We're providing care in the right place and right location. As you know, we have 5 campuses across Prince George's County: Laurel, Bowie. We have our Suitland location, our National Harbor. Currently, we're practicing here in Cheverly, and we will have our location at the Largo campus on June 12th that we will be opening, and we're very excited about that. upgrading our physical environments across all of our campuses, and optimizing our cost structure to make sure that we're doing our part to make sure we're looking at costs and how we deliver care in the future. And then making sure that we have a bilateral focus, not only across those 5 campuses, but making sure that we're partnering with our key stakeholders across the state and within our communities related to the pandemic. And we have learned a lot about the pandemic, and that has ensured that we have relooked at how we set up our infrastructures across our campuses, whether that's ventilation systems, making sure that we have enough ICU beds, not just for this pandemic, but in the future. And that's a part of our planning process to relook at how we continue to invest into our infrastructures so that if we do have such a pandemic in the future, that we are even more prepared. The state's investment is critical to this work. As Ms. Wagner in her presentation earlier showed, one of the grants that was reduced by 1.5 million, and we understand the dynamics and the circumstances surrounding that necessary cut. And while we understand that, we're hopeful that the funding will ultimately be restored, and we are requesting that the committees continue to support these efforts, and hopefully we would restore the funding in fiscal year 21 as we move forward. I again want to thank each of you for your support. I want to thank you for the work that you do, not only on behalf of the communities, but our entire state of Maryland.
Thank you, Mr. Richardson. I know it's been a busy 10 months because I've seen you across Prince George's County. And thank you for giving us the update on the June 12th. I didn't actually have the actual date on my calendar, so noted. Are there any questions for Mr. Richardson? Okay, thank you very much, sir.
Thank you.
I have one other witness signed up, Jim Snyder. I don't see him in the room. Jim Snyder? Okay, hopefully I've not missed anyone who signed up to participate on this budget. If I have, you have 1 second to acknowledge, raise your hand. Okay, seeing none, that's going to conclude the hearing on the budget of the Maryland Department of Health Prevention, Health Promotion Administration. Thank you all very much for your interest and your questions. We're going to now move to the Maryland Department of Health Regulatory Commissions. We have analyst Andrew Garrison. You have the bridge, sir.
Thank you, Madam Chair, members of the relevant committee. Committees, can you all see my screen? Excellent. So today we have the budgets for the health regulatory commissions. And what we're talking about this budget is actually 3 separate independent commissions within the Maryland Department of Health. The Maryland Healthcare Commission, the Health Services Cost Review Commission, or HSCRC, I'm going to be saying that a lot, as well as the Community Health Resource Commission, or CHRC. I'll also be saying that one quite a bit today. The budget here, we're showing an increase of about 14.2 million. And from the dollar standpoint, there's really 2 things that are driving that. And that's an increase in the uncompensated care fund, as well as a contingent reduction happening to the Community Health Resource Commission budget based on a BRFA provision as introduced. And we're going to touch on those both really quickly here at the top. And first, just to highlight, the uncompensated care fund is a way, is dollars that pass through the Health Services Cost Review Commission to balance out uncompensated care between hospitals with a higher amount of uncompensated care to a lower amount. And that really is a large portion of the total dollars that we see here in this budget. Just a little bit, just about under 65%, with all other expenditures across these 3 commissions only occupying that other 35% there. And so again, that is what we have driving that change. We have an increase in the uncompensated care fund of $17 million budgeted this year. And what is offsetting that, so how we get back down to that only $14 million increase is here in the Community Health Resource Commission. There's a contingent reduction, as mentioned, that's going to have an impact of about $4.4 million to the CHRC's budget. And so first turning to the UCF, the uncompensated care fund, as mentioned, this is something that is taking the hospitals that have a larger share of uncompensated care and giving them funds to help offset that from the hospitals that had a lower share of that. And as you can see in fiscal 21, the HSCRC is anticipating almost the entire spending authority that was budgeted in the UCF to end up being spent. Sometimes what is ultimately distributed through the UCF is lower than their total spending authority, and that's what we're showing in fiscals 18, 19, and 20. That kind of shaded area is the difference, but they're getting right up there in 21, and that is due to ultimately in some sort of way an increase in uncompensated care itself. And so in 22, we're budgeting, they're budgeting an increase in the UCF. In total, it's about a $12 million or 12% increase, showing that $17 million increase in itself. And then moving on to the reduction that's offsetting that, that's happening to the Community Health Resource Commission. And in previous years, backing up a little bit, the Community Health Resource Commission gets funding through the Care First Premium Tax Credit exemption. That funding is split between the Community Health Resource Commission and the Senior Prescription Drug Assistance Program. These two programs, as in current law, is the Community Health Resource Commission gets the first $8 million, and then the Senior Prescription Drug Assistance Program gets the rest of that. What this BRFA provision, as introduced, proposes is to switch the funding priority there. So the first half is going to go towards the Senior Prescription Drug Assistance Program, while whatever's left over is going to go to the Community Health Resource Commission. And what we've outlined here on Exhibit 5 is that the total amount of funds that can be used for those two programs from Care First has actually been going down a little bit in recent years. My colleague Simon is going to talk a lot more about the reason behind that and the Senior Prescription Drug Assistance Program when in the Medicaid analysis. But really what we do want to show here is because of those decreasing funds, when this priority is switched as proposed, what that will ultimately do is cut the funding that's available to the Community Health Resource Commission in about half right away. And so that's from that 22 number to that 22 BRFA provision, those last two columns we're showing you there. If this sounds at all familiar, is because it was included in last year's BRFA as well. That was rejected by the General Assembly. And so it is introduced again, and it is introduced such that it would be ongoing. So even beyond fiscal 22, the funding priority would be switched where, again, the Senior Prescription Drug Assistance Program gets the first 14 and the remaining goes to the Community Health Resource Commission. Because the Community Health Resource Commission is largely a grant-making agency, they get about $8 million a year, and about 7.2 of that ends up going out towards grants. We're assuming that most of that reduction is going to come off the grant side. Frankly, there's not a lot of operating expenditures to cut from the Community Health Resource Commission. So we're imagining that this $4 million reduction would all come from their ability to distribute grants to those community providers. So setting aside then the budget discussion, we also take this opportunity to talk a little bit more on the policy front, particularly around the total cost of care model, which the HSCRC is involved in, as well as the broader healthcare delivery system, particularly looking at hospitals in the state. The Health Services Cost Review Commission is also has a role in setting those hospital rates. Last year, in the Joint Chairman's report, there was a request for a community narrative around hospital profits, and particularly hospital profits and sort of the divergence between unregulated profits, which we're showing on the red line in front of you here in Exhibit 6, and regulated profits. And as you can see, while unregulated profits have fallen, regulated profits have increased slightly and increased such that the hospitals are still able to make a net operating profit, which we're showing there in those green lines in the middle. What the JCR in particular asked about was to which extent regulated profits, so payers, either commercial payers or in the case of Medicaid, state payers are offsetting unregulated rates and unregulated losses. And in this JCR submission, the HSCRC discussed two major factors that they are considering driving towards those differences in the rates. One of which is physician subsidies, and the other that was pointed out is total population health goals. To the extent in which the unregulated losses are reflected in investments in total population health, that is ultimately sort of how the system and the hospital pricing should work, because it's harder to capture, but the HSCRC is holding hospitals accountable for a population health goal under total cost of care, that's actually not necessarily a bad substitution in a way where if regulated dollars are then supporting unregulated losses on the population health side. The physician subsidies was also discussed, and in their report as well, the HSCRC mentioned revising their fiscal submissions that are required from hospitals in such a way that would help us better capture or understand the differences between the unregulated dollars showing up as net losses and the regulated dollars, and kind of further understanding that. And so what we're doing here is we're just asking them to comment on the progress of incorporating some of those revisements into the financial statement to better understand these factors contributing to the unregulated losses and the profit margins. While we're on the topic of hospital profits, we can also turn to looking at how the HSCRC was able to assist hospitals during COVID-19. What we're showing you here in Exhibit 7 is the difference in calendar 20 to the prior 2 years averages in both admissions and dollars that was received by hospitals. And what you can see, of course, is in April, really sort of in the full swing of a lot of the COVID restrictions in hospitals, the lack of elective procedures, both admissions into those hospitals and revenues went down pretty precipitously. You will notice, of course, that revenues were able to rebound in short order, while admissions are still actually below prior year levels. And the reason for this is because of our unique healthcare model here in Maryland, the HSCRC was able to allow hospitals to charge up to the global budgets. Even though the volume was down, they were still actually able to receive revenues up to sort of anticipated levels to really sort of smooth out some of the financials for the hospitals that we have here in the state. And of course, the state and the HSCRC weren't the only assistance that Maryland hospitals received during this. There was also federal support through the Provider Relief Fund. DLS currently has been able to identify about $1.4 billion that was received to these hospitals through the Provider Relief Fund. What the HSCRC has told us they're looking to do is sort of once all the final accounting's done from the federal dollars, is they will then take those federal dollars into consideration, offset that against this global budget overcharge that was allowed to occur. So then the total impact in dollars to state payers to supporting the hospitals is going to be reduced. The last time they run that estimate for us, that was around $250 million they estimated would be sort of this net global budget difference. That was back in December, and since then there's been more Provider Relief Fund dollars to enter into the hospitals, so we would actually expect that number to go down a little bit. And just to further underscore this, again, circling back to those profit margins, here in Exhibit 8, what we're showing is that in fiscal 21, so when a lot of these COVID restrictions were in place that were affecting hospital volumes, hospital profits were still above where they were in fiscal 20, largely across the board, even those with traditionally smaller profit margins, kind of shown in the middle of the page there. I would also like to note, in the HSCRC has reminded me of this, that these are still from unaudited financial statements. So this is not necessarily final reporting, but it does sort of show us the directionality of some of the trends that we've seen here in hospital dollars. Turning towards the total cost of care model, the first year results were in calendar 19, and those have been certified by the federal government and CMS. And on Exhibit 9, I'm just going to scroll quickly, but that last column is meeting goal, and the HSCRC and the state has been able to meet all the goals under total cost of care. And there's one goal in particular that I want to highlight on, and that is the savings goal, the savings to the Medicare program now. The HSCRC actually, the state rather, but was able to achieve savings well over what was set for calendar year 19 for the first year under total cost of care, so much so that actually under the contract, they were able to carry over half of that surplus savings, ends up being about $110 million into the savings goal for calendar 20. And that makes the lift for savings in calendar 20 a lot smaller. So you can actually hardly see it, but that's about $40 million that's required for further savings in 20 after considering that carryover amount. So we do want to highlight just the progress of the model in and of itself, but also in particular the savings goal that we're looking at here. The other reports that the HSCRC submitted to the General Assembly this past interim talked about the Maryland Primary Care Program. The Maryland Primary Care Program is a part of total cost of care and works to move these primary care practices towards more advanced primary care, including care management, access to appointments, behavioral health services. And one of the ways that they can that they do that is by having additional per beneficiary per month payments given to participating primary care practices. These additional care management fees that are given to the providers are actually costing against the state's total cost of care dollars. And so those savings targets we were just talking about under Medicare savings. And so because of those sort of conflicting puts and takes, last year, the Joint Chairman's report requested a report particularly looking at sort of the costs of those additional care management fees and if we're seeing any offsetting savings from those beneficiaries in those affiliated programs going to the emergency rooms less or having less high utilization, effectively being lower cost than perhaps some of their counterparts in non-participating practices. And that report actually didn't find any cost savings. Of course, they did note that the Maryland Primary Care Program is fairly new. And so because of that, we're actually having a recommendation here again for similar narrative this year to continue that type of reporting to see the progress both of the Maryland Primary Care Program and again to really look at if there's cost savings that are occurring here from this program that we're benefiting from on the total cost of care model. Lastly, I do just want to highlight a new grant program that is not passing through the state budget because it's being funded through hospital rates, but it is a fairly exciting grant of $45 million a year and focusing on diabetes and behavioral health services. It's really aligning with the population health goals under total cost of care. Anne mentioned in her presentation that the third priority for this is that maternal and child health. So we will be seeing new programs participating next year. That first year of funding was actually directed towards COVID. That would be corresponding to this grant. But we have three behavioral health crisis service programs, and we have then we have 6 diabetes awards programs, and I put those on this map here for y'all, as well as put dots for hospitals participating in either of those programs. Where you can see the blue shaded a little bit darker, that's because we actually have 2 different diabetes programs participating there. And so that's shown by the overlap where the cross hatchings are the behavioral health programs. Ultimately, DLS's only recommendation is again, that committee narrative, repeating that study last year on the Maryland Primary Care Program. That concludes my presentation and I'd be happy to take any questions.
Thank you, Mr. Garrison. Are there any questions from the members? Looks like you've answered all of their questions, sir. Okay, thank you.
Madam Chair.
Oops, I missed one. There you go. My screen was compressed because of the slide. Delegate Henson.
If I may, that was a very comprehensive presentation. I did have just one small question, Mr. Garrison. I'm wondering why Anne Arundel County was not a participant in that last study. Did we have any information on that?
So the I do not know exactly if Anne Arundel County submitted a grant for this. Of course, the counties participating is correlates to where the hospital is participating, where the HSARC would probably be better suited to inform us to like who was who submitted participating grants and those that were ultimately selected.
Thank you. You've helped me understand the selection process better, so now I know where to follow up. Thank you, Mr. Garrison.
Of course.
Thank you, Delegate. Any other questions for the analyst? Going once, going twice. All right, we'll now move to the next part of our agenda, which is, I see you, Mr. Secretary, on camera. I didn't know if you wanted to say a few words in this area or...
If I may, Madam Chair.
Sure.
Thank you. Well, I appreciate the opportunity to be here today and joining with my colleague Katie Wunderlich from the HSCRC and Howard Haft, who is running the primary care model. But we also have Ben Steffen from the Healthcare Commission and Mark Luckner from the Health Resources Commission, as well as our CFO. These commissions are really critical to the state's healthcare system design. Worked very closely a few years ago with Katie Wunderlich and her team when we were negotiating with CMMI to put in place the total cost of care model. This is the foundation of our healthcare system in Maryland and is really quite critical. And these commissions, although small, I would say are mighty. And we rely on them very heavily for the work they do. It's really quite important. So I'm glad to be here today, and we're here to answer any questions that the Joint Committee might have.
Great, thank you very much. So I do have Ms. Wunderlich, Dr. Haft signed up, as well as Mr. Terry on HSCRC. Were you all going to make any remarks? We'll start with you, Ms. Wunderlich.
Thank you. Thank you, Madam Chair and members of the B&T Subcommittee, and of course, Chairman Resnick and the members of the Appropriations Subcommittee. Thank you very much for having me. My name is Katie Wunderlich. I'm Executive Director of the Health Services Cost Review Commission. I want to thank Mr. Garrison for his very comprehensive and detailed analysis of the health regulatory budget and the activities. There's a lot going on across all three commissions, and I appreciate the way he was able to put it concisely in front of you all. I also want to take a minute to thank my staff, Xavier Colo and Mark Hoffman, who helped me on the budget side of things, and to recognize and thank my colleagues Tequila Terry and Megan Renfrew, who also support and lead actually our efforts in Annapolis and in front of the legislature. So I do want to thank those colleagues as well for their support. I'm really proud to be here representing the Health Services Cost Review Commission together with MDH, with MHCC, the Health Resources Commission, hospitals, payers, providers. We have an enormous opportunity to help continue the transformation of healthcare delivery in Maryland through the Maryland Health Model. It's a very exciting opportunity where we can help to coordinate services for patients in Maryland across both hospital and non-hospital services. We have a really unique model, as you all know. It allows for improvement and innovation across the healthcare spectrum to provide for better health outcomes, improved population health, higher levels of quality of care, a coordination between providers at different levels of care, and all of that ultimately leading to reduced cost for institutions and purchasers of care, reduced healthcare costs. Our aim really is to focus on improving health disparities, chronic conditions, improving population health and access to care. All of those elements together, we think will help to reduce unnecessary high cost utilization and result in lower healthcare spend overall. The total cost of care model is a continuation, as you all know, of the all-payer model. It continues the stability and predictability of our system, of the population-based revenue system that hospitals operate under. The model, of course, protects from cost shifting. That means that everyone in the system pays the same amount. That's a really unique and important component and feature of our model, that there is no cost shifting between public or private payers. We also have an equitable distribution of uncompensated care, as Mr. Garrison mentioned earlier, that helps to ensure that Marylanders across the state can access high-level quality of care at their closest hospital and don't have to go to one hospital or another depending on their insurance status. Our model supports infrastructure, health infrastructure in the state, including CRISP, the Maryland Patient Safety Center, our sister agencies, the Sister Commission, the Healthcare Commission, and other important healthcare infrastructure, including graduate medical education, nurse support programs, and countless others. It also establishes Maryland as a leader of quality and delivery reform in the nation, and it's something that we should all be really proud of. Maryland really is leading the way in healthcare delivery and reform across the country, something that I'm extremely proud of, and we all should be extremely proud of as Marylanders. For the total cost of care model, as I mentioned, it's a continuation of the all-payer model, but it does add some important new components, primarily connecting hospital and non-hospital services and quality. It expands our quality metrics to include population health. We've heard about those population health metrics and areas that we're focusing on from Mr. Garrison, which include diabetes, reduction of diabetes burden, substance use disorder, and maternal child health. So we do have a focus on those 3 population health areas that we'll be focusing on as a state to help to reduce those chronic conditions and health disparities across the state to improve health for Marylanders. Another important add-on, which my colleague Dr. Haft will speak to later in this presentation, is the primary care program. We believe that the primary care, the delivery of primary care is a really important component to help address patients' needs on the ground with a provider that they know and they trust to help address those chronic conditions, chronic diseases, and improve health and quality of life. And of course, all of our interventions and approaches are on an all-payer basis, an all-payer approach. That's another strong component of our system that we will continue to focus on and incorporate into our strategies, that we are not trying to promote population health just for the Medicare population. We are trying to promote population health and health improvement for patients and Marylanders across the board. So to the extent possible, we always try to incorporate that all-payer approach. I would like to, before I turn to the issues that Mr. Garrison raised, I also would like to just spend a minute talking about COVID. It of course has upended life and delivery of health. I'm really proud of the work that hospitals have done through this pandemic. There was a lot of uncertainty, both a clinical uncertainty and financial uncertainty when the pandemic started. And they really have been able to pursue, thanks in part to the protections of the model. The model did provide some essential protections for hospitals that allow them to focus on providing care, staffing up, acquiring PPE, and reconfiguring hospital layouts to accommodate COVID and non-COVID. And the HSCRC was able to act independently because we do have rate setting authority to ensure that hospitals had the resources they needed to rise to the challenge of the pandemic when it started last year. As Mr. Garrison mentioned, we are in the process now of reconciling the funds that were received by hospitals from the federal government and from rates, revenue that was charged through rates. We do anticipate reconciling those to ensure compliance with the GBR. We don't anticipate settling up completely until after we can see the final run out of fiscal year 21. So in a normal period, we would calculate our overcharge and undercharge about 6 months after the end of the fiscal year. So if the fiscal year ends in June, we would settle up that undercharge overcharge in January. So there'll be a little bit of a lag time, I guess is the point I'm trying to make in terms of the COVID settle up. And certainly the federal funding that hospitals have received span both the fiscal year 20 and fiscal year 21. So we still are in the process of reconciling those funds. I'd like to now just turn to a couple of the questions and issues raised by Mr. Garrison in the analysis. Again, thank you very much for that great report. The first one was on hospital margins and the connection to unregulated investments. One of the central concepts of our global budget system under the Maryland Total Cost of Care is that hospitals have the ability to redirect funds that were from revenue that was raised under regulated services. They're able to redirect those funds saved from reducing or eliminating unnecessary hospital utilization, and instead redeploy those saved funds into population health and indirect measures to improve health outcomes, ensure high quality of care, and improve population health. And indeed, the regulated revenue funds in part those investments in population health, in physicians, in other infrastructure areas that help to keep Marylanders healthy and improve health outcomes. So we know that connection is there. What the challenge to the HSCRC is to have a better idea and a better way to capture the spend on the unregulated side. We have detailed financial reports from hospitals on their regulated services. So the services that are provided in a hospital setting or in a regulated outpatient setting. We have detailed financial reporting and cost reporting on the regulated side. We have less detailed reporting on the unregulated side. So for physician practices, other outpatient settings that hospitals may own, we have more limited insight into that. And so in order to better evaluate hospital investments in that population health and care transformation initiatives that support the total cost of care model goals, we have developed a preliminary reporting schedule to collect that information from the hospital systems. And so this is from a system level, not from a hospital specific level, because a lot of the population health efforts that hospitals have underway are at a system level and not necessarily at a one hospital level. This preliminary reporting schedule was released to hospitals in August 2020 as part of the HSCRC's annual filing instructions for fiscal year 20. The deadline for hospitals to return the data is March 31st, 2021, and that is an extended deadline. We normally would have had an earlier deadline, but we extended it due to COVID and diverted resources within the hospitals that were responding to COVID. So we do have a deadline of March 31st. And as I mentioned, unlike other reports, this report is going to be at the system level. So that the information that we collect by March 2021 will be used to improve our data collection to see what information we get. It will not necessarily be used in the first year for methodologies or to assess hospital compliance, but rather to better refine that cost report schedule. And just to give you a little bit of a flavor, the reporting schedule collects information on system expenditures and revenue on population health and care transformation. It's reported by regulated and unregulated expenses for each of the hospitals within the system. And some of the data fields include direct expenses, both for physician extender, hospital coverage, population health focused clinicians, community physicians in specialty areas and community health needs assessment, community physicians in primary care, and other community physicians. So all of those direct expenses. It will also include direct expenses for non-physicians, so for care transformation costs or other that are not specifically related to a physician. It will also include information on indirect expenses, both from the physician side and non-physician side, and other related revenue. The preliminary reporting schedule reconciles the expenses to the hospital's annual filing. So that is what we are anticipating collecting and then implementing as mandatory reporting in fiscal year 21 and beyond, so that we can have a better insight into what investments hospitals are making that they're using regulated revenue to support. The second area that Mr. Garrison highlighted was the Maryland Primary Care Program. I want to thank my colleagues at MHCC. They are instrumental in leading the advisory council for that important program. This is, as Mr. Garrison noted, the first year, our report looked at just the first year. And these investments still really are, I think, solidifying. MDPCP, as I mentioned, is a key element to enhance direct patient care at the primary care level. We have a unique opportunity to engage a vast majority of the primary care practices in the state, and will be incumbent on hospitals that run CTOs, the care transformation organizations, and the hospitals that have primary care practices in the program to coordinate, use data, and target efforts to help then eventually improve health and reduce unnecessary hospital utilization. And MDPCP also has the ability to impact SciHIS success in addition to improving health outcomes, to target health disparities, behavioral health improvement, diabetes management, a number of other benefits of the program. And I know Dr. Haft is up next after me, and he will be able to shed more light on the program. But we really do think it's a key element in the overall model, and we do want to see it successful and it succeed on a long-term basis. And then the last area it was not necessarily was for the Catalyst grant programs, and I do want to respond to Delegate Henson's question on the grant programs. First, want to recognize the enormous amount of work that goes on in the planning and coordination for those grant programs from the hospital side and the community partnering the community organizations with the hospitals. We also, as a state, did a lot of work in evaluating and reviewing those grant programs. And I want to thank my colleague, Mark Luckner from the Community Health Resources Commission, who is an enormous source of support and advice on that grant process, as well as Mr. Steffen from the Healthcare Commission. So it really was a group effort in terms of evaluating the grants. They were issued on a competitive basis. We actually had $100 million more in grant requests than we were able to fund. And so it's a good problem to have. There are a lot of hospitals and community organizations, who are engaged and excited about taking on work to improve behavioral health, to reduce the incidence of diabetes. There is a lot of support in the community to do those things. Specifically to Delegate Henson's question about Anne Arundel County, there was applications received. However, because we received more applications than we were able to fund, we were not able to fund with the Catalyst grant dollars those programs from Anne Arundel Medical Center. However, that does not preclude the hospital from working already with their community partners on behavioral health, on diabetes, on other things. So hospitals still have the opportunity to use revenue that they are able to retain on those population health initiatives. But unfortunately for the Catalyst grant program, we were limited in the amount of funds we had to award. That concludes my remarks. I'd be happy to take any questions from either of the committees.
Yes, thank you so much. We're going to pause here for questions, and then we're going to turn to Dr. Haff, Ben Steffen, Mark Luckner, and then we'll pause after those three, and then we'll hear from some members of the public. So are there any questions for Ms. Wunderlich? Vice Chair Valentino Smith.
All right, I seem to have a lot of questions. I do try and read, but so Ms. Wunderlich, you've done a really good job of helping us understand the specifics of the new total cost of care program and how it's being implemented. So I just wanted to clarify a couple of things. We're going to get a closer look then at the unregulated investments, obviously from what you're doing and how they're being set off with profits. But is it fair to say that in the total cost of care program that you talked about funds being redeployed to populations and some indirect measures, that it would be acceptable, at least in the design, for hospital systems to be deploying resources to the homeless and to transitional housing and discharge or the homeless population, and that you would better be able to tell us if any of the health systems have made that decision or not?
Sure. So first, I think absolutely the impact that focusing on homeless populations that don't have access to medical care, safe housing, food, etc., is a very important population to focus on when we're looking at not only overall population health, but also as a hospital looks at its emergency department volume, say, and making sure they have enough resources to take care of everyone. I think that that population is extremely important. I think some of the ways that the hospital spend will show up on the homeless population is through their community benefits report. We would be able to see through the cost reports the indirect funds, the clinics, the communications, the transportation, other things of that nature that they would supply. That would should show up, I would say, on that cost report. Now, we have not gotten those cost reports back yet. Those cost reports are due March 31st. So we'll see in greater detail the level of detail we get, and we can certainly refine from there what we are requesting of hospitals. But I would say it would show up in two places: one, on their community benefit reports, and then two, perhaps in the granular detail of the cost report.
So they get to choose their own community benefit, and it's not that the legislature has decided, at least at this point, the legislature hasn't taken a position to prioritize community benefit for the hospitals.
So I know the legislature acted last year to improve the community benefit reporting process and to better align the community health needs assessment with community input and support, and we have been working through that process. So I think that's a process that is ongoing to improve the community benefits reporting process, and specifically to connect the community health needs assessment with direct input from the community members. So I know you all acted on this last year, and that work is continuing.
Thank you, Madam Chair. Just for purposes of the committee, as House Chair of the Joint Committee on Ending Homelessness, I just add some depth and perception that we've been communicating with the CRC for some time about trying to access what data we can get with respect to those that are discharged with housing insecurity, those that are readmitted with housing insecurity, and what resources under the total cost of care benefit are starting to be deployed for that population. So I just wanted to give some context to that question. The second question, if I may.
Yes.
Uncompensated care. So I know that Mr. Garrison talked to us a little bit about the uncompensated care fund, and we can see that it's being completely deployed. If we could get feedback to the committee on the parameters for the uncompensated care, the geographic jurisdictions, and the healthcare systems that are experiencing the uncompensated care, so we can see if there's a disparity. I'm actually just sensing a little bit more in my own county for Prince George's County. I'd like to see where we're trending with respect to uncompensated care.
So on that point, Madam Delegate, our uncompensated care funding policy is a blend of a hospital's previous their actual uncompensated care, bad debt, and charity care amounts from the previous year, blended with what we project for the next year. And so it's not based on only the actual. So there's a little bit of projection as well. And I can get you a hospital by hospital breakdown of who paid into the fund and who received funds out of uncompensated care fund. So as Mr. Garrison mentioned earlier, this is a fund that attempts to make equitable the financial burden of uncompensated care. So hospitals that traditionally, based on their previous year and what we project, will have a higher level of uncompensated care than the state average, they will receive a payment from the fund. Hospitals that we think will have a lower amount of actual uncompensated care will pay into the fund, then the state average will pay into the fund. And so that gets reconciled each year, and I can get you a hospital by hospital who pays into the fund, who receives money from the fund. But I think it is really important. It's such a founding principle that unlike other states, we do not have public hospitals. We do not have a hospital dedicated only to public payers. our Marylanders can go to any hospital across the state, regardless of their payer, their payer type. So I think that's a really important distinction. And the other comment I would make, I think that perhaps might mirror what you're feeling in Prince George's County and your own jurisdiction. We have seen an increase in uncompensated care, as the chart from Mr. Garrison noted. Since 14, there was really a decrease. Since 2014, the expansion of the ACA and individual health benefits, Medicaid, uncompensated care was declining because more people had coverage. They did not experience, they did not have to self-pay. There was more people covered. Now, in the last 2 years, we've seen a slight uptick in uncompensated care. And we believe that's not because there are less people covered, but we believe that it is because there are more individuals that have coverage that cannot afford to pay for their out-of-pocket deductibles and copays. So they have insurance, but they cannot afford to pay those deductibles. And that's why we're seeing this very small increase in uncompensated care that's resulting from patients that do have coverage but can't afford to use it.
Thank you, Madam Chair.
Thank you, Delegate. All right, I have Senator Eckert.
I think I'm unmuted. Thank you very much, Katie, for a wonderful analysis as possible. And you may answer this, but not today if you don't want to, because I know we're under a time constraint. First of all, primary care is included in that unregulated section, correct? Of patient care. And in that hospital profit margin, is it realistic to expect that the gap will lessen? And if so, what might influence that?
The gap
between the net and the regulated amount and then the unregulated. There's a very wide gap there. And is it reasonable to expect under certain conditions that would narrow? Or is that not what's anticipated? Or is that chart not really capturing it?
And before you answer her question, I want to piggyback on it so you can combine your answer and then we can, I just want to follow up on that. I wanted to get a sense of how we, because we are so unique in our process, how we compare to other states in terms of profit margin. If you can kind of envelop that in your response.
Sure. So from a high level system view, Maryland health systems are less profitable than the national average. However, I would note that while the nation can have swings in their profitability, Maryland hospitals, because of the GBR, provide some stability and predictability in their revenue stream. And that's especially important for rural hospitals. Rural hospitals in other states can see big drops in their revenue because of volume drop-offs. In rural hospitals in Maryland, there is a little bit more predictability. It's not a perfect system, but it's a little bit better. And specifically through the pandemic, when hospital profits nationally were tanking, we were able to keep hospitals relatively stable in order to provide funding that they needed for the pandemic. So overall, Maryland hospitals have a lower margins than the nation, but the volatility is also less. So there's a little bit of a trade-off there. In terms of the gap between regulated margins and unregulated losses, I think I'll have to give that a little bit more thought, Senator Eckert. We are doing our best to recognize where those unregulated investments are incurring. There is some funding through the Maryland Primary Care Program for hospitals that operate as CTOs that can help offset some of that unregulated losses for primary care, but that's just a kind of a one-off. So if you wouldn't mind if I can give it a little bit more thought for that one.
That's great. Thank you very much. Appreciate it.
Yeah, and thank you for your response to mine. I would be interested. I'm an old pensions nerd, as many of my colleagues know. So I guess I'm curious long term, if we were to smooth out, over an extended period of time, whether or not those comparisons with other states would work out to be something comparable, or whether there's a dramatic difference even with the predictability. So if you can, you don't have to follow up now. I know we have a lot of folks still ahead of you, but I'd love to hear more about that.
Absolutely. Absolutely. And when I follow up with you, I'll also, we are in touch with the rating agencies in New York on a regular basis, and they continually note the stability of the system, the HSCRC and the Maryland model, as a positive in the rating when they do their ratings.
Okay, thank you very much. I don't see any additional questions for this witness, so we will move to Dr. Half, then Ben Steffen, then Mark Luckner, in that order. Gentlemen, good afternoon.
Thank you, Madam Chair, and thank you, Chair Resnick and committee members. It's a pleasure to be here. I also like to thank the analyst, Mr. Garrison, for his excellent analysis, and particularly like to thank Katie Wunderlich and Ben Steffen and all of my colleagues who worked together in this total cost of care contract. It really is a joint effort for the entire department. And I'd like to just start by pointing out that in so many ways, Maryland is leading the nation in terms of finding a solution, a credible solution, a statewide solution to this vexing problem that we've had in the nation for decades now, very high costs and questionable quality and high degrees of disparity. So it is truly an honor and a privilege to be able to participate in this program that's leading the way for the nation in so many ways. And I will be very brief because you do have a lot ahead of you. The specific question that was raised to us was regarding evaluation and particularly looking at savings that might be brought to the total cost of care contract by virtue of the work being done by the Maryland Primary Care Program. So I'd like to report that now, just beginning its third year, the Maryland Primary Care Program has 564 primary care sites across the state. It makes this the largest program of its kind in the nation, by far. And it's pervasive, and in the practices that are in the Maryland Primary Care Program now care for 2/3 of all Marylanders every day. It is a foundational program because it is primary care, and we're the first place that most individuals look to receive their care. It includes now a large number of our federally qualified healthcare centers. 44 of those sites around of our program are federally qualified healthcare centers. So broadening the reach and particularly reaching out more to our vulnerable population, something that was a hard-fought negotiation with our federal partners. And I'd like to also report that in terms of ongoing careful look at the analysis of how the program is doing, is that we're engaged both with the HSCRC on an annual basis, and we'll continue to do that. We have independent data contractors and analysts who look at the data on an ongoing basis, so we can not only monitor the program itself, but the individual participants in the program. And we're working with Mathematica, who is our federal partners contractor for looking at the overall performance of MDPCP within the total cost of care contract. So we have at least those three ongoing analyses. As was pointed out in year one, no one expected that there would be any significant savings. And just as no one expected, we produced exactly that result. There were no significant savings. However, even in this tumultuous year of 2020, we've looked at the data to date, and there are two really bright shining points that I'd like to bring to your attention. When we look at the Maryland Primary Care Program compared to the state as a whole in terms of hospital utilization, the state as a whole has 236 hospital admissions per 1,000, and Maryland Primary Care Program 174. So a significant decrease in terms of compared to the state as a whole. This is for Medicare beneficiaries specifically, a decrease in utilization, also a decrease in hospital utilization, a modest decrease of 358. as opposed to 361 for the state, but significantly a marked reduction in readmissions at 11.7% in readmissions for the Maryland primary care enrolled beneficiaries as opposed to 16% or so overall. So, this is a tumultuous year, and I think 2020 is interesting data, but not anything we would write home about in terms of being normative for any other year. We did, however, during 2020 want to take a specific look at how our practices did compared to a very closely matched cohort, looking at COVID vulnerability index, age, sex, a whole host of very closely matched cohort of patients who are not in the beneficiaries who are not in the primary care program. And very interestingly and importantly, we noted that for those patients who were cared for by the Maryland primary care program, that they had fewer COVID diagnoses, fewer admissions, statistically fewer admissions to the ICU, and very statistically significant fewer deaths from COVID. And to me, that's even more remarkable than any other data that we would be able to show to the General Assembly or anyone else regarding the work that's done by these practices every day. And I think it's a testimonial to the ability for public health, for the hospital systems and primary care to work together in a very data-driven, very analytic, very purposeful goal of reducing unnecessary and avoidable admissions and addressing those important things that are right in front of us, like a COVID pandemic. Again, this can't be done in any other state, and it's just a testimonial to the forethought of Secretary Schrader and those who are on the federal side in contemplating a program that pulled together all these essential pieces of a healthcare delivery system under one focused roof, and particularly with a focus at population health and health equity. So I'll just stop there for the sake of brevity.
All right. Thank you, Dr. Half. Mr. Steffen.
Thank you, Chair Griffith, members of the committees. Very briefly, Ben Steffen with the Maryland Healthcare Commission. I'm the Executive Director. I wanted to touch on four areas very quickly that I think the Commission and the staff are extremely proud of. But before I do that, I want to recognize several staff that are with me today. They include Richard Proctor, who's our Chief Operating Officer, Tracy DeShields, who is our External Affairs and Government Liaisons Head, and Diana Denbach, who's our Chief of Administration. It's been a rough year, but I think the Commission and the Commission staff saw opportunities, and we moved very aggressively to try to respond to the needs of the health of the residents of Maryland. First off, responding to the governor's request, we, along with the Office of Healthcare Quality, worked aggressively in those early days to expand hospital capacity, adding through emergency CONs and temporary licensure of capacity over 3,000 additional hospital beds in Maryland. Fortunately, many of those beds were not needed, but it does demonstrate the willingness of Maryland hospitals to expand quickly. In the April and May period, in the public health literature, there was considerable concern. Maryland was pointed out as one of the states where hospital occupancies are already high, a factor related to our payment system, and there were worries that we would quickly overflow the system. The hospitals in Maryland, working with the state government, local government, and residents, were able to never really exceed the capacities of the state. Secondly, we recognized, especially during the lockdown period, that the need for telehealth was going to be enormously greater. Our staff had been longstanding advocates, and we worked not only with large health systems, but engaged small providers in bringing them up to speed in telehealth. Specifically, we worked with about 120 small, principally primary care providers in bringing their systems up so that they could begin delivering telehealth services shortly after the pandemic fell upon the state. Third, and this is really recognizing work that we've already done, that we realized that information on the quality of Maryland providers was in higher demand than ever. During those first several months, our nursing home website got enormous visitations. However, what we also realized is the information needed to be more accessible and more timely. We are now redesigning our quality reporting initiative, and beginning in March of this year, we'll launch a new, more user-friendly, accessible site that will cover not only nursing home services, hospital services, hospice, and home health as well. And we're looking forward to showcasing that to residents in the state. And fourth, we've worked very aggressively with our other state partners in making information that the Maryland Healthcare Commission collects available and accessible, not only to the Health Services Cost Review Commission, but also to the Health Benefit Exchange and to the Prescription Drug Affordability Board and our close partners in the MIA. We've made information that's helped and guided their policy decisions moving forward. So we appreciate your attention today. We are continue to work with our colleagues across state government to making Maryland a more safe and efficient healthcare system. So I'll stop there and happy to take any questions.
Thank you so much. Now the very patient Mark Lechner for the final budget area. Mr.
Madam Chair, it's good to see you again. Thank you very much. I've been called many things patient. Thank you for that. I'm going to use that with my 5-year-old here in a minute here who's bouncing off the walls here. Home at school today. Madam Chair, good to see you again. I'd like to thank the governor for his allowance. I'd like to thank Mr. Garrison for his analysis. And I'd like to thank the members of your two subcommittees for your continued legislative support. I'll be very, very brief. At the Community Health Resource Commission, we're about 3 things. 1, serving vulnerable populations. 2, working with many folks in today and many others to help break down the barriers in accessing healthcare for health disparities. And 3, helping promote ongoing COVID relief and recovery. Those are our priorities: vulnerable populations, health equity, and social determinants of health, and COVID relief and recovery. Earlier this year, Madam Chair, you asked us to brief you on what we did for the emergency funding RFP for COVID. We're happy to work with the Department of Health to provide us federal resources to award 46 grants totaling $1.5 million. Many of those grants were to support telehealth, like Mr. Steffen said. Right now, we're in the middle of a current RFP, our annual RFP, which looks at helping support Maryland's Diabetes Action Plan, helping serve vulnerable populations, and as I said, COVID relief and recovery. We've got 55 proposals before us, requesting 13.7, and we can award 6.7. So with that, Madam Chair, I would be happy to answer any questions, and thank you again for continued legislative support of our commission. And also give our very small and highly productive staff a shout out as well. Thank you for everyone.
Absolutely. Thank you. Questions for this panel, members, Dr. Half, Mr. Steffen, or Mr. Lechner? I see Vice Chair Valentino Smith.
It's like a game show. Am I just first on the button?
Come on down.
Thank you. I had a question for Dr. Half and then for Mr. Lechner. So Dr. Half, it's always really exciting to hear you talk about the Maryland Primary Care Physicians Program and your hopes for what it is to accomplish. So with respect to the unfortunate theme that we see in our data that has to do with disparities in healthcare and real widening gaps for our Black and Brown population, my question is, for this program, which is a voluntary program to all qualifying Maryland primary care providers who deliver advanced primary care in Maryland, and for the 562 practices that you have participating, are you able to give us a breakdown with respect to the number of minority providers that are participating? And are you able to give us a breakdown with respect to the number of minority recipients compared to the rest of the population? In other words, are we seeing equity here, or are we unfortunately maybe, I hope not, seeing continued trends and disparity with respect to who is in these practices and receiving the advanced primary care coordination?
So thank you for that very good question. And yes, we can give you a breakdown in terms of both the the race and ethnicity of patients who are served by the practices compared to the state as a whole, and the amount of services that they receive. We don't collect data on specific data on the race and ethnicity of the providers, but I can check to see if we can get that perhaps out of their application process. We do have 2,150 providers, and we serve every county in the state, and 26 care transformation organizations also that serve every county in the state. I believe, to be absolutely frank with you, that there remains a gap between those who are served in primary care that represents still some lack of equity. Now, I think it's offset by the introduction of our federally qualified healthcare centers, who represent a much broader, much deeper representation in terms of the underserved or unserved communities, the Black and Brown communities specifically. And we hope and anticipate that we'll see a greater admixture. We have about 44 of the about 11 federally qualified healthcare sites in the state are in the program now in the first year of their ability to register. We hope that that number grows so that it will offset what is just a fact of the way the healthcare is delivered now, that it is not done in an equitable fashion. But having said that, we own that. We do. We own that. We know that it's an issue. It's an issue with vaccines. It's an issue with testing. It's an issue with every way we deliver healthcare. But I think we're focused on identifying those issues. We're very intentional in including in our educational programs to the practices and our technical assistance and our data, real data and real focus on where those gaps are, and real programs and how to bridge those gaps. And this is, again, unique to Maryland. Most other states can't say they do this for all their primary care providers.
Thank you. I appreciate your sincerity and acknowledging the disparities that exist, and hope that when we see the data that you present us, that if it continues to show that disparity, that your energies are deployed towards reaching those practices and really bringing them into the program for our minority population. So my second question, if I may, Madam Chair, is for Mr. Luckner.
Briefly.
So thank you, Mr. Luckner. I mean, it was very nice of you to praise the governor's budget for your allowance, but I just want to make sure I understand. It appears that if the BRFA goes through, that your allowance may actually be reduced. And so from a dollar perspective, again, to our minority populations, it looks like the majority of your unique funding and grants goes towards helping those in our minority. And you said disparity. So are we risking financing for that population with the BRFA amendment?
Let me see if I understand your question, and thank you for that. I guess the best way for me to answer it would be that I would agree with Mr. Garrison's analysis,
Okay.
which states that the language of the BRFA would result in a $4.4 million cut of our $8 million budget. That is factual.
And is that $4.1 million cut likely to impact those in our minority populations more than others?
At the Community Health Resource Commission, we have these strategic priorities: promoting health equity, serving vulnerable populations, and right now supporting COVID relief and recovery. So if our budget were to be cut by $4.4 million, that would negatively impact our ability to reach those priorities.
Thank you. Thank you for the answer. Thank you, Madam Chair, for your patience.
Thank you, Madam Vice Chair. We'll go to Senator Eckert.
Thank you very much. For Dr. Half, thank you very much for your explanation, all the exciting things that you've been working on. I want to piggyback on Delegate Geraldine
Valentino Smith.
Valentino, thank you very much. It's the end of the day and I've been sitting a long time. Her comments, because we are concerned about equity with our workforce and what we need to do to be able to provide incentives to get more people more equitable participation in our workforce. So we have a couple of bills, and we hope you'll work with us on those bills as they move forward as a part of the work product from our Senate work group this summer that was chaired by our chair of our subcommittee here, Chairman Griffith. So we look forward to working with you on that. And then I did have a question for Mr. Luckner, because it was going to be the same thing. My sense is that you work with the most vulnerable populations, and even though we were able to get some more money in the short term, get it out the door, which I hope will be helpful. It's very specifically designed for two different groups. So that's probably over and above what you already have in the pipeline. So I was going to ask the same thing, what impact is that reduction going to have on our vulnerable populations and inequity? And I think you've pretty much answered that, but I know you probably have a list that'll further define that. So thank you for your response. Thank you, Madam Chair.
Thank you, Senator. I don't see any additional hands, so I did want to acknowledge Dr. Half. I appreciate the work with the primary care community and understand why the numbers may not be looking like what we'd want to, just considering the period of time we've been kind of collecting this impactful data. So please keep us posted. I think it's probably in terms of the work that you're doing, and you and I go way back to your work in Charles County when I was doing some work there. But I recognize that a part of it is educating the consumers as well. And so we have to do a little bit of that. And so look forward to hearing more positive reports moving forward. Mr. Stephan, thank you so much for your work with the telehealth as we try to make sure that we have quality care provided in the way that makes the most sense for each recipient of care. And Mr. Luckner, my colleagues have already stated it. We know that there are some immediate resources coming to address health disparities, but we are concerned about the out years and making sure that we don't do meaningful interventions in the short term, but that we're not able to sustain them, as we saw with the infant mortality and maternal mortality. We have to go to the long term. So we appreciate that and your work and your response. Members, we have several witnesses. We're going to hear from Lori Doyle and Kevin Keenan. I don't see Pam Casemeyer, but she's also signed up. So good afternoon, Ms. Doyle. Thank you all so much for your patience. I know it's been a long afternoon.
Thank you, Chair Griffith and Chair Resnick. Lori Doyle here on behalf of the Community Behavioral Health Association of Maryland, in support of full funding for the Community Health Resources Commission budget. And I don't think I could say it any better than a Delegate Geraldine Valentino-Smith or Senator Eckert said. This commission is the only one that looks at the social safety net, that looks at those very things that impact our communities that are economically vulnerable, communities of color, communities who experience the impact of disparities and the social determinants of health. Most community programs live hand to mouth. They don't have the kind of resources that it would take to spark innovation and make the kinds of investments in these sort of approaches that we need to do if we're going to move forward as a state and really see justice in the health realm. So I hope that you will reject the BRFA cuts to the CHRC budget and provide the full funding so they continue to do their great work. There have been some really wonderful grants that have shown remarkable returns on investment, not only financially, but in the health of Marylanders. So thank you for your time. It's been a long day. Much appreciated.
Thank you. Mr.
Good afternoon, Chairperson Griffith, Chairman Resnick, and esteemed members of the committee. My name is Kevin Keegan. I'm the Family Services Division Director for Catholic Charities of Baltimore. Each day, Catholic Charities staff interacts with Marylanders facing some of the most challenging and difficult situations, and frequently it's involving systemic inequities, particularly when it comes to accessing high-quality health care. When you begin to talk about COVID-19, it really has made the challenges even more dire. Catholic Charities has partnered with the Community Health Resources Commission on numerous projects over the past 10 years, and we've seen firsthand the transformative impacts these grant funds can produce. we frequently use words like innovation, integration, and improving access to care. You know, we work hard to work with the state to improve outcomes for immigrants, for youth and behavioral health crisis, for families lacking access to appropriate health care and supports for their families. CHRC is one of the rare funding sources that provides opportunities to support these. It allows us to think outside of the traditional boxes we must usually fit into, to be eligible for funding streams such as Medicaid. It allows us to test these opportunities while we work to establish positive outcomes and sustainable funding sources, meanwhile providing innovation and integration that truly improves the lives of some of our most vulnerable neighbors. The project I'm most involved with has allowed Catholic Charities to convert all of our 9 outpatient mental health centers to now also be able to serve substance use disorders without having to go down the street to have those separate needs met. It really allows us to serve the whole person. But to accomplish this, there was an extensive amount of training for over 200 clinical staff. And without CHRC, there's no way you actually have the resources to support such a monumental shift in our practice. And then especially during times where the opioid crisis is going, and just because it hasn't been in the press over the past year because of COVID, it's certainly as bad as it's been. It's even more important for OMHCs like ours and others to have an integrated treatment program for all of our clients and their families. And the transition is fairly well complete now, and we're able to access traditional funding streams like Medicaid to provide these life-saving services. So in light of that, I just can't highlight the importance of CHRC enough, and Catholic Charities of Baltimore urges the committee respectfully to reject any attempts to reduce funding for the Community Health Resources Commission. Thanks for your consideration and your time.
Thank you. And I see Ms. Case-Myers on the screen. Good afternoon.
Thank you, Senator Griffith and members of the subcommittees. I can't add to the substance of what both Ms. Doyle and Mr. Keegan said, but the other thing I would say in support of maintaining the funding structure for the Community Health Resource Commission, quite frankly, most of my clients would like to see it increase. But aside from that, if we can keep it protected, that would be great. But what I would say, as importantly as you all are the stewards of state money, this is one of the most effective commissions or efforts I know in state funding to ensure accountability of its grantees for the use of the money that they get, and to leverage other funding, whether it be private funding or federal funding. The report that the commission produces every year can demonstrate that hundreds of thousands of dollars generated in either private investment or federal funding as a result of the state grants, and the accountability measures that they hold their grantees to ensure that the state's dollars are very well spent. So that would be the other additional comment I would make as you consider not only their budget, which this year in the budget is fine, but are concerned about the nexus with the BRFA language, which would both cut the funding and reprioritize funding long-term and put the commission's work at tremendous risk.
Thank you. Thank you for your comments. Thank you all for your testimony. I don't think, and I'm going to ask the chair of the House Subcommittee, I think I've covered all of the witnesses on this budget, and certainly we've had some fantastic panelists as well. Unless I've missed someone, that would conclude the hearing on the Maryland Department of Health Regulatory Commissions. And I thank you all for your presentations, and thank you to our analyst. I'm going to turn it over to our House Chair, Chair Resnick. You now have the con.
Thank you, Madam Chair. And I want to apologize to everyone. I did completely intend to wear a tie today. I brought it and only just like 2 minutes ago realized I never put it on. So I apologize for my lack of decorum. We're going to go ahead and move to the budget for the Child Support Administration and start with the analyst. It's been a while, so I forgot who the analyst is for the Child Support Administration. So,
Grace Pedersen.
Hi, Grace. How are you? Grace, take it away.
Okay, thank you, Mr. Chair. I'm just going to share my screen. Can y'all see that?
Yes.
Okay, great. So it's my pleasure to present the Department of Human Services Child Support Administration Fiscal 2022 Budget Analysis. The Child Support Administration, his main goal is to enable, encourage, and enforce parental responsibility. As you can see in this first graph, the budget, the fiscal 22 allowance is relatively level from the fiscal 2021 working appropriation, about a 1% decrease. Most of the agency's budget is for personnel, followed by cooperative reimbursement agreements. The budget changes most significant for special funds, which increase over 40%, while general funds decrease over 10% and federal funds decrease 6%. So more special funds are being used to offset some general fund need. Making up the $1 million decrease in the budget is the removal of 12 positions seen here at the bottom. It accounts for $812,000 of the decrease, but that's partially offset by some other personnel increases. Another significant decrease is the reduction in rented space. So I mentioned earlier, 12 positions are abolished in the allowance, but DHS indicated that all of those are long-term vacant positions and won't have an effect on agency operations. Then I have 3 key observations for you today. The first one pertains to the pandemic's effect on child support administration. So there are 4 key functions of child support administration, the first being paternity establishment, which was affected because genetic tests are performed via mouth swab, which presents hazards to both CSA employees and the test participant. And then these genetic tests are not being collected until a court case is actually scheduled. Then court closures also affected support order establishment. Child support matters weren't adjudicated at all until phase 3 of the court's reopening plan, but most hearings were postponed until at least November 2020, and even then only limited hearings were offered. Collections is interesting because while employers face sudden closures or reduced operations for their businesses that contributed to a decrease in wage withholdings affecting collections on current support, temporary enhanced unemployment insurance and temporary expanded unemployment insurance contributed to an increase in collections on current support and collections on arrears. The stimulus payments were also able to be intercepted for child support arrearages. So you can see here in Exhibit 4, these are child support collections, and 2020 collections were higher than any other year in the past 10 years. And you can see this substantial increase in cases paying towards arrears. As I mentioned, the current support paid is relatively level from prior years, and that's probably because of that interaction between the lower wage withholdings but the increased unemployment insurance collections. The second issue I have for you also pertains to performance. So each year, the federal government distributes performance-based incentive payments to the states. So if a state performs relatively well compared to other states, it would receive a higher payment. Whereas if a state performs relatively not as good compared to other states, they would receive a lesser incentive payment. And then, as shown in Exhibit 5, these are the lower thresholds. If any of those aren't met, the state could be liable to pay a penalty for not meeting those minimum performance measures. However, the state, Maryland, met all the minimum thresholds and even exceeded the national average for collections on current support and cases paying towards arrears. However, Maryland's performance in paternity establishment, support order establishment, and cost effectiveness was lower than the national average. So I want to specifically turn your attention to cost effectiveness. Maryland was one of 14 states to collect less than $4 in support for every $1 spent on child support enforcement and administrative activities. And this represents a decrease from prior years. Fiscal 2019 decreased substantially from fiscal 2018, and fiscal 2020 performance indicates that the state's performance further decreases, but national data isn't available yet. So despite this decreased performance and cost effectiveness, the state's incentive payment is expected to remain relatively similar to 2019 and 2020. So incentive payments are distributed on a 2-year lag. So this 2019 payment was actually reflective of federal fiscal 2017 performance. The 2020 payment was reflective of 2018 performance. So the 2021 payment will be reflective of 2019 performance. And that was the first year with that significant decrease in cost effectiveness. So while these are relatively high, considering that 3 of the prior 5 years received incentive payments of less than 9 million, the state will also be using more special funds to offset general fund need. So if these incentive payments aren't as high as is currently projected for these revenues, the fund balance for these federal incentive payments could be substantially depleted by the projected spending of these funds in fiscal 2021 and 2022. So then I'll jump right to the third key observation, and this has to do with the Baltimore City privatization contract. Baltimore City comprises the largest share of the state's child support caseload and is the only jurisdiction that has a privatized contract for child support administration. The contract is structured to mimic this federal incentive payment model so that the vendor would be eligible for an incentive payment if they exceed a certain threshold of performance, but they would also be assessed a penalty if they don't meet a minimum service level. So the minimum service levels were met for cases with support orders, paternity establishment, and cases paying toward arrears, which arrearage collections actually were higher than the incentive threshold. However, the minimum service level for current support collections was not met. So the vendor was assessed a $100,000 penalty. And they also didn't receive the incentive payment for cases paying toward arrears because the minimum service level for one of the measures wasn't met. So DLS is recommending to request periodic updates on the vendor's performance, but also statewide performance and each jurisdiction's performance. So here is that recommendation, and that concludes my presentation. I'd be happy to take any questions.
Wonderful. Thanks, Grace. Any questions for Grace? Delegate Henson.
Thank you, Mr. Chairman. Grace, you mentioned that the special funds was I don't know, I can't remember if 5.1 million was the increase or if it was the special fund balance. I was trying to figure out if it was in any way connected to the increase in child support payments that you noticed that I guess were related to the pandemic with the increased payments that came in through the unemployment benefits. What is the source is my question, I'm sorry. What is the source of the special funds increase that we're seeing there?
So fiscal 2022 is using more special funds from the Child Support Reinvestment Fund. So those the reinvestment fund is holding the federal incentive payments that the state has received in prior years. So that's going to be used to offset some of the general fund need. And those special funds, so general funds are matched by federal funds, but those special funds, the Child Support Reinvestment Funds, are not eligible for a further match. Does that answer your question?
It does. Thank you. Thank you. Thank you.
All right. Thank you. Any additional questions? Seeing none, thank you, Grace. We're going to move on to the department and call on Secretary Padilla, Mr. Kevin Geistwhite, and Mr. Stafford Chipongo. I know they were in earlier. So there they are. Welcome, Secretary Padilla. Please kick it off or have your team present. I don't know if you're speaking, we cannot hear you. Sorry, but we still cannot hear you. Okay, now you're on mute. Now you're off mute. Nope. This has been happening a little more often recently on Zoom. Would it be possible for you to leave the Zoom and then come back in and you'll be let back in? That might work. Or you can call in. Yep, they just popped off. Okay, let's give them a minute to come back in. Hope everyone had a nice Valentine's Day. Okay, looks like they're back in. We see you, but you are on mute. There we go.
Okay, great. Okay. Thank you, Chairman Griffith and Chairman Resnick, for the opportunity to discuss the 2022 fiscal year budget allowance for child support administration. As you stated, I have my team here today on Stafford Chikongo, Chief Financial Officer, and Gavin Guswai, who is the Executive Director of the Child Support Administration. As always, I want to take the time to thank Grace Pedersen for her comprehensive and concise analysis of the HHS budget. She's a pleasure to work with, and we appreciate all her support. I also want to thank the local and metro directors and their staff for all their hard work through the past year, and especially during the COVID pandemic. Without them, there is no DHS. You have my testimony, which I won't repeat here. So what I do want to say is that in 2020, despite the pandemic, we had a very strong year. We collected $583 million in child support, distributed 153 of that millions to former TCA families, and the collections per case increased by $40. And we continue to support orders, establish support orders, and we're on our 4th year of the Step Up Non-Custodial Employment and Training Program. If I may now, with your permission, I would like to move to address the issues and recommended actions in the analysis.
Please.
On the recommendations, the department concurs with the analyst's recommended actions. Moving on to issue number 1, regarding the factors affecting declining cost effectiveness ratio. The primary factors affecting the declining cost effectiveness ratio are information technology costs and staff cost of living adjustment. IT expenditures are currently higher due to the cost of maintaining the legacy child support system while also developing the new child support system. On issue 2, regarding adopting narrative, requesting updates on the vendor's performance in addition to statewide performance data, the department concurs with the analyst's recommendation. This concludes my testimony and response, and I will be happy to address any questions the committee may have. Thank you.
Thank you, Madam Secretary. Are there any questions for the department? Delegate Henson.
Thank you, Mr. Chair, and thank you, Madam Secretary, for your testimony. I couldn't help but wonder what the fate of the families was as Ms. Penderson laid out that during the pandemic, we were not able to establish paternity as effectively. And then during the pandemic as well, not able to establish child support as effectively either because of the closures there at the courts. Was the department able to, through its other arm there with DHS, able to partner with the families that sought your aid to provide some sort of temporary support for families that came there seeking to establish child support? And also, was the department able to use the affidavit process for establishing paternity in lieu of offering the genetic testing to be able to still give families some sort of certainty and resolution during the pandemic?
Delivery of essential child support services to customers continue uninterrupted while local child support offices are open to the general public by appointments only. I can say that most of the child support staff are teleworking with only limited staff reporting occasionally to offices to complete the mission critical or essential duties. And I'm now going to let my executive director of child support elaborate on my response and address your questions more specifically. So Kevin, if you would.
Thank you, Delegate Henson, for your question. Yes, we were working with our customers as much as possible during the pandemic. We offered many different situations where if we could prevent enforcement actions from occurring, such as driver's license suspensions, we did suppress those, especially during the time when we cannot get the orders modified to the courts as quickly as we would like to during this time. We also worked on consent agreements with the customers where possible, since those at least we could start working with until we can get the orders reviewed by the judge. And then we also worked on AOPs. We were able to continue the process, but we did see delays in AOPs, which is affidavits of attendant parentage, in the hospital settings during COVID, where they weren't able to put the focus on that service as much.
Thank you, Mr. Geiswhite. Mr. Chair, may I be permitted just one more question?
Yes, of course, please.
Thank you, Mr. Chair. It's disappointing to hear, if I'm hearing you correctly, Mr. Geiswhite, and I was having some trouble with the volume, just hearing you exactly clearly, but it sounds like they were also having trouble establishing parentage by affidavit in the hospitals as well, just due to COVID and the limited amount of availability for visitors and all the other protocols that we had to put in place. So it sounds like we probably have a number of children that were born last year that are looking to have that certainty there with parentage. But my second question dealt with the incentive payments and then the effective costs there with the $4 for every $1 spent. Have you analyzed at all the collection rate on the cases as it relates to the support amount? It's my understanding that lots of times, or I won't say lots of times, it's my understanding that establishing a child support amount based on a presumption that a parent is voluntarily impoverished and assuming an income for a parent, and then establishing a support amount based on what the department believes a parent can pay, sometimes disincentivizes parents from being able to try to meet that obligation because it's just too high for that parent, but it can have the opposite effect. Instead of encouraging payments, discouraging payments. Have you looked at ways to right size orders or do anything to increase the rate in which you're getting payments by way of adjusting the support amounts and working with the families to do that?
Yes, again, during the pandemic, we have been working with families as much as possible to get orders ready to go to the courts. The challenge, of course, has been getting those orders through the court process due to the closures to either modify or establish orders at that rate. Our goal is, of course, to ensure that we're establishing orders based upon ability to pay, and we look forward to being able to do more of that in the future as well as we get through this pandemic.
Thank you, Mr. Geiswhite. Madam Secretary, thank you, Mr. Chair.
Thank you. Any other questions for the department panel? Seeing none, I want to thank the department for coming and presenting today, and I believe that concludes our budget hearings for the day, and we will see everyone in Wednesday, if I'm not mistaken. Thursday, sorry. We'll see everyone on Wednesday for Appropriations Committee hearings, bill hearings. So we'll see everybody then, except for our fair senators. We'll see you guys on Thursday. Goodbye, everybody.